I mentioned here inhibition can be initiated at the limbic level of the brain. Motor information or sensory information of movement comes up the cord. It's integrated at the limbic level, goes out to the cortex, comes down through the cerebellum, and then goes back out on the sensory side. This is the root, and apparently the limbic level can have nuclei which will inhibit certain things when they start to act. But the whole thing is integrated, and the process of facilitation, where all of the other muscles are recruited and brought in for a particular kinetic chain. Now I mentioned the fact that the body monitors all the time, but it is like antenna. And the interesting thing about the nerve ending is that it has a particular shape and form. For instance, there's an organ called Krauss end bulb. Then we have a little nerve that runs around the tendon and around the muscle fiber, and it's spindle shaped. It's wrapped around, so if something happens in the tension of it, if it decreases or increases, that's the way the nerve picks up the stimuli. So we have the Golgi apparatus, fibers of Vater Pacini, those should be capitalized, and Ruffini should be capitalized because these are all people's names. Muscles do not grow in length by the addition of new fibers. It seems as though we are endowed with a certain number of muscles and a certain number of nerves at birth. What actually happens is an addition of the individual units, or what are called sarcomeres. All right, just like learning has to be done by repetition, learning of a function has to be done by rehearsal. The famous Paderewski said, if I miss a day's practice, I know it. If I miss a week's practice, my audience knows it. So if we have a habit that we want to correct, we have to have a rehearsal. I should also briefly tell you about Steindler, Arthur Steindler. He was to orthopedic surgery what Engel was to orthodontics. He was trained in Vienna, and he came to the United States prior to World War II. In 1950, I was asked to be a dental correlator for all of the principles that he had developed in orthopedics. That summer, attempting to study what he had to offer. And many of the things I've told you today, I learned from him in 1950. It's hard to believe that's 40 years ago. But a principle will stand forever. Techniques are ephemeral. So one of the things that we have to remember is that in dealing with anatomy and physiology, it doesn't change. Take your mouth, move your lips to the right side, and feel you pull your tongue back and want to move it to the right also. See how you have a tendency for the tongue to follow the lips? So there's an equilibrium between the tongue and the lips. That's muscle. What you have here is a case before treatment. This is him here. What I did was to take his frontal and trace it. Then I traced his frontal photograph. Now what I want you to do is to take this photograph tracing and put the muscles of the mouth on it. Let's do the Mentalis muscle. I described it to you the other day. It comes downward and forward.
それで、前下方に伸びてきます。
And it inserts out into the soft tissue of the chin. Now what the Mentalis does is that it elevates the soft tissue of the chin. This is Mentalis.
これが音外筋です。
Now, when the Mentalis is active, it pulls this up.
これが上に
Ordinarily, there should be a smooth,
ばられ
even
ます。
distribution of the chin
普通であ
around the
れば
symphysis.
この結合部周囲は均一
When
に
the mentalis is active,
力が分布されているのが筋肉が分布していますが、このメンタリスがアクティブになりますとこのようになります。上に行きます。
so this part of the chin is raised.
お互いのこの部分が上がるわけです。強調されるわけです。
Now, by compression, it pushes the lower lip up. It doesn't pull the lip up, it pushes it up. This part of the lip right here is very dense.
この
So it is dense, and when the mentalis pushes this part up,
非常に
it
密で
pushes the lower lip up.
お互い
A patient with a long face or a protrusive denture, unless they have an abundance of lip structure,
よっぽどこの口唇部の構造がたくさんあ
are
る人
going
が
to
ない
have a mentalis hyperfunction. Now they look more chinless than they are. Keep in mind that it can be due to a long face or a protrusive denture or a short lip. Now there's something very interesting about the mentalis also.
もう一つ
When I first came to California, there was a saying, if you want to make a protrusion, you want to make a double protrusion and you want it to stay, make it a good one. In other words, make it excessive. At the same time, in Tucson, Arizona, it was said that it's impossible to get a lower denture too far back. Here's the same symphysis.
同じ学校付け都合ですけどこんなです。
Now, where's the lip in these two cases?
両方の場合、口唇はどこに来ているでしょう。
The mentalis is here.
音外筋はこっちです。
And when the mentalis is there, it forces straight in on the lip like that.
で、音外筋がこういう角度で口唇を引っ張ります。
Now the mentalis is here.
こっちはこういうふうに筋肉がつ
And as
い
it
ていて、
picks the lip up, it's going down the long axis of the root rather than perpendicular to it.
その場合、
So the mentalis is perhaps the most important single muscle to understand in orthodontics. Now next,
次
there's
で
a
す。
muscle that starts right here,
ここが
just about over the lower canine.
で
And it comes up into the lip,
こういうふうに口唇の方に入ってきます。
riding over the origin of the mentalis.
音が
This muscle comes in from the side,
横
right
か
in
ら
here,
入ってきている筋肉です。
and it comes in from the side here. And in 25% of the population, joins with the opposite side, the Quadratus Inferioris. It's the one I operate,
私がオペするのはこれです。
because right in the midline, it turns to fascia. And there's a raphe-like material right in the lips in these real tight individuals.
で、数字以
Turn
上
to
に
your neighbor
隣の人と向き合ってください。
and show them the inside of your mouth.
口の中見せてあげてください。
Now, if you look very careful, just lateral to the raphe, you will see the two mentalis muscle origins.
数壁部のすぐ隣のところに2
See
箇
the
所
muscle right
音
through
外
the
筋の基地
tissue.
がわかると思います。
On page 180, you've got a bilateral protrusion and a bilateral retrusion.
両側
Notice that the mouth that is full is also wide in this instance. The girl on the lower side there
から下の方の図
had remarkable crowding in her arch,
この
and a dentist went in and took out all 4 canines.
それで
And it left the girl with such a flat mouth that she was very much embarrassed.
少しの結
And
論
be totally unacceptable in an Oriental face. When I get to my lecture on aesthetics, you will find that a person with high cheekbones
で、後で新美性のレクチャーで言いますけども、例えば東洋人のように非常に胸骨、頬骨の高い人、例えば先生みた
See
いな
these high cheekbones?
非常にチ
Look
ー
at
ク
her
ボーンの
prominent
高い人
cheeks. That will take a fuller mouth with a lot of beauty.
悪くなってしま
So
いま
when
す
you have high cheekbones,
胸骨の高い人は
you can go ahead and fill it out and it all blends. But if you take somebody with good cheekbones like she has,
でも彼女みたいなチークボー
and
ン
you
の高い
flatten her out,
人をこんな口のところをフラットにしちゃったら
this girl sat in my chair and cried. I just hate my ugly mouth.
自分の顔なんて大嫌いだって泣いてます。
I just hate that dentist. And so we had to go in and open some space.
そこで、少しスペースを空けて
What we did was open the space up distal to her first bicuspid. It's awful difficult to put a bridge in for the canine because it's on the corner. You also need the bone up here to fill in the mouth. Now in the other one we extracted. This one was so protrusive we took some teeth out.
これはもう抜歯し
Now
た症例
these
です
are mouth inharmonies.
ものです。
The upper to the lower lip are related pretty well. One's too far forward, one's too far back. Now we're dealing the next group with lip imbalances. Up the top, you see, you've got
181ページ、リップインバランスというページだと思い
an
ます。
upper lip that's ahead of the lower lip too far.
で、
That's a pro version of the upper lip.
上
You see that in either Class 2 Division 1 or Division 2.
あ
But
一類
usually
二
the
類
lower denture is also back a little bit. Now the one in the middle is an anterior crossbite.
で
That's what we call the lip eversion.
これは
The case below is short lips. You don't have enough length to either the upper or lower lip. They're all imbalances. Now, the ones on the page 182, if you notice, this patient has a protrusive denture with Mentalis habit, also has a long face.
また下です。
If the lower face is long,
ローアフェイスが長いとします。
and the lips has to stretch over that long distance to get closed,
で、長い
the adaptation takes place by a Mentalis habit.
そうします
Now, when you get a long face and a protrusive denture both, you got double duty. I had one girl that was like that,
そう
and
いう
this poor girl went around carrying a box of Kleenex
彼女はいつもクリネックスの箱を持って歩いてました。
or a handkerchief,
あるいはハンカチを持ってました。
and she was always doing
でい
this
つもこうやって拭いてたんです。
because she could not get her mouth shut to contain her own saliva. Obviously a surgical case.
それは
Now the reason that I'm showing you these is because we want to diagnose them
でなぜこういったいろんな
with the
例を
individual muscles involved.
出してるか。
All three of these cases have a quadratus problem. Very common in Class 2 Division 2, but it's present in Class 1, Class 2, and Class 3.
しかし
You can almost see the lines in the face there. See this muscle that I just drew for you.
今
There's also a small incisive muscle that runs parallel to it.
インサイシブマッスルが走ってい
A
ま
lot
す。
of orthodontists have been reluctant to move the denture forward in cases like this
こういう
for fear of relapse and for fear of stripping. Stripping is, stripping of the roots. It's also called recession. Now, if I move the teeth too fast and I rotate the mandible at the same time,
で、あまり
I'm going to produce a pressure atrophy. The pressure is too great on the soft tissue, squeezes out the blood supply, tissue dies,
で組織が壊死して
and you get recession.
退縮する。
There are two orthodontic techniques that recognize this situation. The first is the Bemmler and the Frankel device. They put shields down in this vestibule, and they use this tight lip right here. I invented the bumper
私がバンパーを発明しましたけど、
in the early 1950s. I put bands on the lower first molar and put a wire down inside the lower lip. Use headgear tubes on the lower molar,
で
and then just fit this right above the sulcus.
で、
The lower lip was so strong in many patients that it moved the molars back 3 millimeters on each side. Now some patients have very loose flaccid lips and it's not going to have the same tension on it. The black race has very loose flaccid lips.
黒
Big,
人
thick, and soft lips.
柔らかくてしかしてるんで
And
す。
large tongues.
で舌も非常に大きいです。
You take teeth out of them and try to bring it back, and you end up bringing everything in the back up to where the front teeth were to start with. So in those cases, if you extract, orthodontics is the art of losing anchorage. So we have lip sucking,
で口唇壁がある場合、
sublabial contraction,
このリップサッキングがある場合
and
ですけれども、
paraoral contraction
その
all
場
the
合
way
にはこの
around.
真ん中と下の例になります。
Tightness through here.
この下唇下の拘縮、それから
The number one problem in diagnosis, as far as I'm concerned. Now what I try to do is treat the problem rather than treat the teeth to the problem. Now, let's go ahead with these muscles right out around the mouth. The next one is the triangularis. I used to have a cadaver that I kept in the office, and we had all of these muscles dissected out so I could show everybody directly these muscles. And the girl forgot to put it away under water or under the solution one time, and it dried out, so I lost it. But it was a beautiful exhibit. We had all the facial muscles on one side and the muscles of mastication on the other side of the same specimen. So absolutely gorgeous. Very unhappy when I lost that for our courses here. And the canine fossa. It originates in the canine fossa, and it runs down to the corner of the mouth, where it joins with the triangularis and runs down to the lateral border of the mandible. Now that's one muscle. In the dissections that I made, I could not see where the caninus started and where the triangularis ended. And I would call it one muscle, because the two absolutely work together. Now there's a saying in orthodontic that you can't expand canines. Now frequently the inner canine width of the lower will be back to where it started from. Now this simply has to be due to some physical environment. So this strap that runs right across the corner of the mouth is the binding influence against expansion through the canine. But now in respect for this complex of muscles, you see it in our 4D design, in which we deliberately
でそのデザインではどうやったかと言いますと、故意に
tuck the canines in because we know they're going to relapse. Open up the arch,
アーチを拡大して、
bring the lower incisors through and uncrowd them, and then tuck the canines in behind, and the forefront teeth will remain straight. So this is one of the first things that I did when I came to California. Because the number one side of relapse in the lower arch is the lower lateral incisor. It wants to go lingual.
どうしても絶足に行きがちです。
So the first thing I did
そこで
was to put a bayonet
バイオネットはつけるん
in
で
the
すけども、
opposite way.
逆に
Put a little gable there,
反対ですからゲーブルベントにし
so
ま
that this would be to the labia rather than to the lingual. Now we continued that
す。でそれから次、
until we started raising the brackets on the canine. Now we use a
今
thicker bracket here
ここにはもっとその大きなブ
to
ラケット
tuck
を
the
つけます。
canine in. So I call it the CT band. Okay. Now let me see if I can go through these muscles. Over the top of
ここ
that
に腱子筋があって、
is the
その上には
Quadratus Inferioris,
こ
which
れが
holds the
口
lip
角
up.
挙上筋があって上心を上に引っ張る働きがあります。
It has an angular head.
ヘッドがあり
And
ま
there's
す。
a zygomaticus muscle.
この横に走っています。
Then down in the cheek,
その頬のところに行くと
there's a risorius muscle.
小筋があります。
It's the one that makes us dimple when we smile. Some of them only have a dimple on one side because they only have one risorius muscle. Now deep to the risorius
この
is
もっと深いところ
the buccinator. And it originates just about at the depth of the sulcus. Now, it reinforces the tension of the CT band. It crosses over
で胸筋というのはここを通過していきます
and
が、
muscles from the top
でこの上から
cross over and run to the lower
と
lip.
で
Muscles from below cross
そ
over
れから下から来た筋肉というの
and
は
run to the upper lip.
上の
The orbicularis oris is made up of slips and extensions of all of these muscles running into it. So these muscles then just disappear into the orbicularis, which form a sphincter around the mouth. You have incisivus muscles in the upper lip.
上唇には接歯筋があって。
But for the most part, the upper lip doesn't have much tension in it. Now, ordinarily, the lower lip comes up over the front teeth. Now I'm making it harder. Okay. Okay. All right, that's my lip line. Teeth together, mouth together, and don't pull your upper lip up or lower one down. Mark it right where your lip. The tendency when the lip is up too tight, the lower lip is up too far.
でこの下唇がその上に上がりすぎていると。
Class 2, Division 2.
2級2類。
In development, the lower lip's here.
発達の途中では下唇がこういうふうになっていて、で上顎の接歯がだんだん前に出てくる。そうすると下唇の方が強いですからこうなってます。
It goes into a deep eye. Now, where does the buccinator stop? The pterygomandibular raphe. The buccinator comes through there. That accounts for this space there.
ここにスペースが少しできま
The
す。
temporalis muscle comes all the way down to here. And a study in dissection was done at the University of Illinois showing that the temporalis muscle has some strands of muscle that go right down and connect with the buccinator. Now, what's attached on the other side of the pterygomandibular raphe? The superior constrictor. Dr. Brody, who was my teacher, for the fact that there is one continuous strap of muscle that surrounds the denture. If you remember when we discussed the occipital bone, there's a tubercle called the pharyngeal tubercle. Right above basion. See that knob there? Now, the pharyngeal raphe attaches right on that tubercle, right there. All right, now, the pharynx then is suspended right from that point. Now, coming down, you have 3 bands.
でここから3つのバンドが降りてきています。
The first band is attached to the mandible at the pterygomandibular raphe. So this means then that from the raphe backward,
そしてこのラフェから後方は
there is a muscle.
筋肉があります。
Then the buccinator from that on around the denture this way.
そこからぐるりと歯の周りを胸筋が囲んでいます。
So this makes a whole band circling the denture area. But the function of this area is to push the food down into the esophagus. But it's also to suspend the hyoid bone and the larynx and the tongue. And the second band, the middle constrictor, goes down to the area of the hyoid, and the third band, the lower band, goes to the larynx. Now when we swallow, this whole complex is raised up. This forms the muscular walls of the denture, and really it establishes the outside limits. Now let's talk about the problems on the inside. First of all, we have a problem with actual size of the tongue. There are macroglossia and there is microglossia. We know that when we've seen patients with cancer of the tongue and had a part of the tongue removed, the teeth will collapse slightly in the absence of a support from the inside. We know that a mouth breather that is chronic, holding the mouth open for long periods of time, that the upper teeth will come in as a crossbite, either unilateral or bilateral. In the class 3, the tongue seems to be held low, and it also tends to be a crossbite. All of those we have as circumstantial evidence that the tongue is quite important to us. Now the second situation is one of position of the tongue at physiologic rest. The tongue is held forward by the genioglossus muscle, and since the hyoid bone is the skeleton of the tongue, usually when that happens also, the geniohyoid is also hyperactive. Every action has an opposite muscle so that inhibition can take place and smoothness of motion can occur. So the muscle that pulls the tongue back is the styloglossus. So we have the styloglossus pulling it back, the genioglossus pulling it forward, and the geniohyoides pulling it forward. What brings it up? Two muscles are attached to the base of the tongue on the side. One goes to the palate, one goes to the pharynx. Now, distal or posterior to those two muscles is the salpingo pharyngeus. It goes to the eustachian tube. Now, if you think about the lateral throat wall right inside the superior constrictor, the first two muscles are divided by the tonsil. Now, in back of that, then, is a long muscle that hooks into the lateral throat wall. It runs up to the eustachian tube to help milk it and keep it open. All of these tend to raise up the lateral throat wall and raise the tongue. Now what pulls it down? All of the infrahyoids.